Good morning, and welcome to the second session of Health Matters. My name is Margaret Raffin. I'm a longtime member of this community and serve on the Stanford Healthcare Board and chair the Stanford Medicine Community Council. It's my great pleasure to welcome you today, and so wonderful to see so many people turn out to learn more about what happens here at Stanford Medicine, not only in patient care delivery, but also some of the leading edge advances in research and technology. So thank you all for being here today. It is my great pleasure to introduce our speaker today, Dr. David Marin, who is the Clinical Professor of Medicine, Cardiovascular Medicine, and Director of the Preventive Cardiology Department. Dr. Marin received his undergraduate degree from Stanford University, his medical degree from the University of Southern California, and trained at UCLA. He was a Robert Wood Johnson Clinical Scholar, a Preventive Cardiology Fellow, and subsequently a Cardiology Fellow at Stanford University. He served as a faculty member at Vanderbilt as Director of Preventive Cardiology and had the great wisdom and our good fortune to return to Stanford in 2014, where he serves now as Clinical Professor of Medicine and Director of Preventive Cardiology. Dr. Marin's research interests include primary and secondary prevention of coronary artery disease. So please join me in welcoming Dr. David Marin.
Thank you. You married Tom Raffin.
Yeah. Thanks. Good friend.
Good morning, and thank you. How's the sound? Is it good? Too loud? Oh, thumbs up. Okay, great. Thanks for coming. I know that this is an unseasonably cold day for May in California. I am not going to give a lecture. I know that's what you came for. I really want this to be a give and take and make sure that I answer the questions that you have. And I'm going to ask the first several questions just to warm us all up. But anytime, raise your hand. We have mics, and so everyone can hear your question, and I'll try to answer your questions. So I created a top 10 list. And this is the first question. Low fat, it's a statement. Low fat diets are better than high fat diets for your heart. True or false? Okay, so this is a very educated community, and it's gonna be tough. And I may be asking you questions, and well, I am going to be asking you questions, but you may be the ones with the answers. It depends on the type of fat. It's a false. It's false. Now, we, in the last several decades, have heard a mantra that low-fat diet is the way you should go for your heart and for pretty much everything. It's healthier to have a low-fat diet. So what the message is, unless you're Time Magazine, what the message is that we should eat a low saturated fat diet. The total amount of fat, not so important. Where do we get saturated fats? They're shown on the slide. What's the number one source of saturated fat in our diets? Someone said pizza. Someone else said cheese. Yes, that's correct. It's cheese, and it's primarily from pizza. We eat a lot of pizza. And then cookies and cakes and ice cream and other whole-fat dairy products. Red meat is actually, that's what I think of as number one, saturated fat, but it's not even the number one in the American diet as the source of saturated fat that we eat. But, this shows it now. There's also a coconut shown on this slide, and there's a lot of controversy about coconuts. Are coconut oil good for you? It's a saturated fat. If you have so-called virgin coconut oil, it may not be so bad. In general, saturated fat, bad. Coconut oil that's not virgin, bad. Eggs. You like to eat eggs. Okay. What I never understood from the egg industry is why they didn't just encourage everybody to throw away the yolk and they would eat more eggs and just egg whites, because egg whites are such a healthy food, great source of protein, no fat. But the very latest dietary guidelines say that eggs are, don't worry about eggs. Now, why would people worry about eggs at all? Because the cholesterol, there's maybe 250 milligrams or so of cholesterol in an egg yolk. And the point is that dietary cholesterol is not a huge contributor to serum or blood cholesterol. And so we, naturally associate our blood cholesterol with cholesterol in our diet, and we want to avoid it. But in fact, it's not a big deal. There was a big study published from the epidemiologists at Harvard looking at egg intake and the long-term risk of heart disease. 1 egg a day, no increased risk unless you have diabetes. That was a result of that study. That led to a Time magazine cover that I didn't make a slide of today, showing a smile with the 2 big egg yolks. You might remember that one from a couple decades ago. Now, Time magazine last year really confused the issue with this cover. If you read the article, it does elucidate that saturated fat, not good. It says it in the article, not on the cover. The cover says eat butter, which I think is really irresponsible, because there is no controversy that a human being who eats saturated fat, their cholesterol goes up. Their LDL, the low density lipoprotein, the bad cholesterol goes up. It's not controversial. What happened was, instead of getting the message, eat a low saturated fat diet, we got, as I said earlier, the message, eat a low fat diet. And we replaced saturated fat with carbohydrate, and predominantly simple carbohydrates. So, there was a lot of excitement that ding-dongs and other high sugar foods are okay, and they were marketed as low fat, things that are really high in sugar, and that did not improve our health. If you replace saturated fat with polyunsaturated fats, like corn oil or soybean oil, or with monounsaturated fats, like olive oil, canola oil, fats that are in nuts, avocados. If you make that kind of substitution, that's healthy, it's good, and you can have a high-fat diet like a traditional Greek diet, 40% of calories from fat, and have a very low risk of heart disease. But that's because the saturated fat intake in a traditional Greek diet is low. Or you could have a traditional Japanese diet that's very low in fat and also low in saturated fat and have a very low risk of heart disease. There are different types of diets that are healthy. This is one type of fat that you should avoid. It's hydrogenated or trans fats, and they are disappearing from our food supply because of in part because of food labels and public awareness, You don't get them in French fries anymore, or in cupcakes, or whatever kind of popcorn. They're really disappearing, but that's a bad fat. Now, the message that the American public got was in the late 50s, early 60s, around the time that Ike Eisenhower, at the age, I think, of 64, had an MI, and it was very publicized, and he was in a wheelchair, recovering for weeks from his heart attack, and there were twice a day news, press conferences about his how he was doing, and there was a lot of attention paid to his diet. The public really got focused on this, and the American Heart Association said eat a low-fat diet, and our total fat decreased. This is where we are today. Our saturated fat decreased, but our carbohydrate increased. And during several decades, what happened was we went from being the states that are white just don't have any data in them, but the light blue, less than 10% of the population was obese, and the darker blue was 10 to 14%. And then fast forward to 2010, we've become a fat nation. Now, I'm looking in the audience, and it looks a lot different than the audience that I saw in Nashville, Tennessee, which is sort of the buckle of the stroke belt and the heart attack belt. A lot of obesity in our nation. You guys are not representative. And yet, we went from being less than 10% to now 20 to 24% in California. That's where Nashville is, in the darkest, more than a third of the population obese. And that was related or associated, I think, caused by this misinterpretation of avoiding saturated fat. We avoided fat entirely, substituted it with simple carbohydrate, and had a bad public health problem as a result. You could superimpose a map of diabetes on top of the map of obesity. The genetic predisposition, meaning a parent with diabetes and becoming overweight, leads to type 2 diabetes. It's much higher chance. Okay, next statement. Cholesterol deposits can be reversed by diet. True. Good. It is true. I wish I had, well, I'll explain with the next slide. Here on the top are coronary arteries from monkeys that were fed a high-fat, high-cholesterol diet for 1.5 years. The monkeys were then sacrificed, and their coronary arteries were examined. And they were really clogged up. There's very little room for the blood to flow through, and there were blood clots. It was bad. A group of monkeys that got that same diet were then fed a low cholesterol, low fat diet without a lot of sugar for 3.5 years. And then they were sacrificed. And their coronary arteries, examples of their coronary arteries are shown in the bottom two panels. Much less atherosclerosis. So the inference is that they had really clogged up arteries. These monkeys had arteries that looked like this, and then they had regression. Yeah, it was an all-around low-fat diet, but it was replaced with monkey chow. And the monkey chow isn't like eating, cookies and cake. It was more whole grain type of monkey food. So, in fact, I have to go back and look, but this was a paper by Armstrong, and I think they used coconut oil. I'm not sure, in the atherogenic diet. So we have the evidence in non-human primates. I haven't shown you, but I'll tell you, in this area of the country in particular, you've probably heard of Dean Ornish. And Dr. Ornish fed people with coronary artery disease. He did an angiogram at baseline in people who participated in the study, the Lifestyle Heart trial, and he had them change their diets to very low total fat and high complex carbohydrate. In addition, aside from a dietary intervention, there was also exercise and meditation, and food was provided. He made it relatively easy to adopt the healthy food pattern that he was encouraging, and then repeated the angiogram after a certain period of time and found that there was less, and he had a control group that didn't get that treatment. And he found in the follow-up angiograms that the arteries of the people who got the low-fat diet, who had a reduction in their cholesterol, had a less progression and in some cases regression of the atherosclerosis. So you were right, it's true that with diet alone, you said, although there were other things going on in the Lifestyle Heart Project, in the monkey study, it was purely a dietary intervention, that diet can stop the progression and in fact induce regression of atherosclerosis. All right, fish oil. Yes?
Using it not more than I ever did.
The question is, why has coconut oil been getting a good rap? And there have been a couple of small studies looking at virgin coconut oil and the effect on cholesterol. And it has shown that the virgin coconut oil raises HDL and lowers LDL cholesterol, which is what we would think is a good thing. There are no long-term studies looking at the impact of coconut oil on coronary arteries or on the long-term clinical outcomes like survival. Very hard to do a dietary study like that. There are no, there's no evidence except for short-term studies on lipids, which appear to be good.
Regular coconut oil. You mentioned
I
that
think,
they may have.
yeah, I have to go back and look at the diet, but typically coconut oil has been used in diets to try to create atherosclerosis. Yeah. Okay, fish oil. Supplements prevent heart attacks, true or false?
False.
Yes, you're right. It's false. I see so many patients taking fish oil, and I ask them why. And usually they shrug their shoulders and they're not really sure. It's very popular. Sales have gone up continuously over the last 15, 20 years. Exactly. The comment is people think that omega-3s are good for you, and if they're not eating fish, they're taking the fish oil. And I think that a lot of people make that rationalization. There is strong evidence that eating fish reduces the risk of dying from heart disease. Very consistent observational data. It's really very persuasive, and there's a dose-response relationship. The more fish you eat, the lower your risk of dying from heart disease. Does it matter what kind of fish? That's a good question. And it probably doesn't. It probably doesn't, but there is a lot more attention on fatty fish, which reduces the coagulability, the clottiness, how stickiness of blood. There may be antioxidant effects. And in high doses, and you can only get this from fish oil supplements, in really high doses, fish oil will lower triglycerides. I'm talking about at least 2,000 milligrams a day of EPA plus DHA. You may know that there are some prescription fish oil medications that the FDA has approved. They have high doses of EPA and or DHA. Those are the fish oil, the active ingredients, if you will. When you see a bottle of fish oil, it may say 1,000 milligrams in bold on the front, and then you look at the ingredients on the back, and there may be 350 milligrams of EPA and DHA on the back. If you're taking it for triglyceride lowering, then you would need, for example, at least 6 of those to get to the 2,000 milligrams of EPA and DHA. Now, fish oil may have some benefits. If there are anti-inflammatory effects, it may help with arthritis. But if you're taking it to prevent a heart attack, you're wasting your money. There have been so many studies now showing no benefit, that there's no benefit, even though the evidence, it's really disappointing when you believe something and the evidence doesn't support it. This is one of those things. If you eat fish, yes, sir.
So if it lowers in high doses, if fish oil lowers, if fish oil lowers your triglycerides, then why would it have no effect on heart attacks?
Good question. So first of all, it's a little controversial whether or not triglyceride lowering reduces the risk of heart disease. There is growing evidence that high triglycerides are a risk factor. It's been sort of ignored relative to LDL cholesterol. And there has not been a study yet of people with high triglycerides who were treated with high doses of fish oil, followed for enough years to see if it reduces the risk of heart disease. In the people who have been studied for generally primary, I was going to say primary prevention, healthy people with no symptoms, taking 1 fish oil capsule a day, no benefit. So it's still possible that a high dose of fish oil might reduce the risk of heart disease. That study hasn't been done. There was another comment or question? Yes.
So what's the benefit of eating fish versus taking fish oil supplement?
Good question. What's the benefit of eating fish versus the fish oil supplements? I don't know. It's hard to fool Mother Nature. You know, eating fruits and vegetables reduces the risk of heart disease. And so you would think, especially if you're Linus Pauling, you would think that taking vitamins that are in those fruits and vegetables would reduce your risk because it must be the vitamins. Well, lots and lots of studies have been done now in thousands and thousands of people with vitamin supplements showing no reduction in heart disease risk. And unfortunately, among smokers, you take vitamin A, and the risk of heart disease goes up. Actually, it's the risk of lung cancer goes up. So I don't know the answer, but there's something in fish that's good for you.
Eating more fish versus not eating any kind of meat at all.
Right.
Sorry.
So the question,
Yeah, right, so-
vegetarian versus,
Right, like societies that maybe rely a lot on legumes versus for their protein versus fish. Is there some way to compare that so we understand whether fish is net beneficial or not?
yeah, that's a really good question. It's one that I've asked. I've been curious about that. Again, we don't know. To do that study, you would need to take, vegetarians and then add fish to half the group and follow them for a long period of time. Observational data suggests that fish is always beneficial, but it's never really been studied in a vegetarian population. So I don't know. There was another.
I think you answered the question, but maybe I'll ask it a little bit differently. Could it be as simple as by eating fish or eating fruits and vegetables, you're not eating beef or other foods that contribute to heart disease?
Yeah, that's a really good point. And I think that there's probably an additional benefit from eating fruits and vegetables. But it's so hard to do dietary studies because you're always substituting. You're not just taking something away. You have to replace it with something. And so is it the subtraction or is it the addition? And it's very hard to answer. So I don't know. I'm saying that a lot. All right, so we've kind of covered this. Whole grains prevent dying from heart disease. True? No? False? Okay, so at least there's something here that you're not all definitely right on. The answer is true, and this is based on an observational type of data. It comes from people at Harvard again, who have done these long-term studies of physicians and nurses and had them provide dietary information and follow them for a long period of time. And if you eat whole grains, and what you can't see is what these different graphs are. This is the amount of whole grain intake here, and this is the risk of dying. And the more you eat whole grains, the lower the risk. Now, ultimately, unfortunately, we all die. But this is over a certain period of time. And so you can delay your death by eating more whole grains. Now, this is for all causes of mortality. This is for cardiovascular disease mortality. And there's a greater reduction. It's 15 to 20% reduction, depending on how much whole grains you eat. And they had a bottom line that with every serving of almost 30 grams of whole grains, there's per day, every additional serving per day of whole grains, there's a 9% reduction of cardiovascular death with every serving. Pretty big. You have whole grains 3 times a day. Compared with somebody who doesn't, you have nearly a 30% lower chance of having cardiovascular death. So whole grains as opposed to simple carbohydrate. Eating cake 30 grams 3 times a day does not translate into benefit. So what are the 3 S's that should be avoided in a heart-healthy diet? Sugar, salt, saturated fat. I can't teach you guys anything, okay. All right, Mediterranean diet reduces the risk of heart attacks. True. Okay, so what are the, I'm having a little technical difficulty there. What are the components of a Mediterranean diet? Okay, red wine, olive oil, vegetables, fish, pasta, nuts and seeds, vegetables. I think olive oil, what? Beans. Yeah, you mentioned everything except cheese. No. You mentioned everything except low-fat dairy, unless your cheese was a low-fat mozzarella. So, yeah, these were the clues which you didn't need. V for vegetables, fruit, whole grain pasta, seafood, legumes, nuts, and low and non-fat dairy products. So that's what's in a heart-healthy and a Mediterranean diet. This is what a heart-healthy diet should look like. Yes. Oh, okay. So there's a little chicken there, but fish, and there's not red meat in this photograph. The bread is whole grain, the pasta is whole grain. You get the idea. The chicken should be skinned. Yeah, and not fried, which is, fried chicken is the 5th most prominent source of saturated fat in our diet. Okay, cholesterol deposits can be reversed by exercise. True. Now, this is a case where when we do something that we think should be good for us, is good for us. It is true. The data are, we don't have a lot of data on this, but I'm going to show you a little. Now this is, the first piece of data comes again from a monkey study. Monkeys were fed an atherogenic diet. Let's see what they say here in the abstract. No, they just say atherogenic diet, meaning something that would really raise their cholesterol. And then half were put on a treadmill and half were kept sedentary. And after a certain period of time, and I can't remember how, it was at least a year, I think it was more like 2 years, they again sacrificed the animals and examined their coronary arteries. And on top is the coronary artery of a monkey who was in the control group who didn't exercise. And in the bottom is an exercising monkey. The monkeys that got the atherogenic diet and didn't exercise had heart attacks. They had complete closure and blood clots, and they had much more thickening of their arteries with plaque. The monkeys that exercised had some atherosclerosis, but look at the difference in the size. This is the same part of the coronary artery in a different animal, and it's like 2 to 3 times as wide. I mean, it's a much bigger artery, and there's less atherosclerosis. And the only difference between the monkeys was whether or not they exercised. So pretty strong evidence, again, in a non-human primate, that exercise reduces atherosclerosis, and another finding that it increases the size. Well, this would translate to cardiovascular exercise. The question is, what kind of exercise would this translate into? These monkeys were put on treadmills, and exercise, I don't think this, but basically they were walking and running. The slow heart rate is a training effect. People who exercise a lot have slower heart rates. So it would translate into walking, for example. Do you have to work up a sweat? No. And the really, I was advised not to show you a lot of data so that you didn't get too bored. But there are graphs that I could show you about physical activity and dying from heart disease that basically show that the greatest benefit from exercise is going from being a couch potato to doing a little exercise. There is incremental benefit if you go to high intensity exercise and you do it all the time. There's a little benefit. I'm pausing because I'll come back to my pause. So the big thing is doing something. Getting more active, or running instead of walking. Going for an hour instead of 30 minutes. Getting your heart rate higher generally translates into better outcomes. I say generally because in the last half year, there have been 2 or 3 studies looking at sedentary people, these are large population studies, versus people who do a moderate amount of exercise, versus the outliers who do a lot of high intensity exercise. And the high intensity exercisers did not fare well. They actually had a death rate similar to the sedentary. Now, it's hard to believe that. It kind of goes against most of the evidence, but at least 2 large population studies showing that. And it might give some of you some comfort with what you're doing. Yeah. Cardiovascular death, heart death, and then total cause, all cause. But cardiovascular mortality, yeah, surprising. No. Atherogenic meaning like high butter, high saturated fat. Yeah. So atherogenic meaning it creates or generates atherosclerosis. So human beings, now these are monkeys. Here is part of the coronary artery autopsy of Mr. Marathon, Clarence DeMar. Mr. DeMar ran 100 marathons in his lifetime. He won the Boston Marathon 7 times. And when he died at a ripe old age, he had his body donated. And one of the authors here you may recognize as Paul Dudley White, who was, I believe, the cardiologist of President Eisenhower. Very famous cardiologist in the middle of last century. And what this coronary artery shows is, and this is taken from this article, is that the coronary arteries were unusually large, 2 to 3 times normal size. And there was very little atherosclerosis. Now, this doesn't really prove anything. He may have been born with big coronary arteries. But it's remarkably similar to the photo I showed you in the previous slide of the monkeys who did a lot of exercise. And there's another study that I haven't created a slide of, but I'll tell you about. It's looking at human beings with coronary artery disease, proven by an angiogram, a cardiac catheterization, who were randomly assigned to an exercise intervention or control group that didn't, they didn't do as much exercise. And they were followed over time. And the group that exercised had significantly fewer deaths, heart attacks, angioplasties, bypass surgeries. So exercise does affect atherosclerosis. We know from the animal studies that you can inhibit the amount of atherosclerosis and that you actually enlarge the coronary arteries.
Same thing hold for a person who's had a heart attack?
Does the same thing hold for people who have had a heart attack? The study that I just told you about were people who had heart disease. Yes. So raising HDL prevents heart attacks. True or false? Gotcha. Finally. Yeah. So far, no soap. So far, not true. And we have observational data. By that I mean you study a bunch of people, but you don't experiment. You just collect information and see what happens to them over time. A prospective observational study, a population study. Consistently, they show that people with high HDL have a lower risk of heart disease. But that's different than showing that if you raise HDL, you reduce the risk of heart disease. And it's sort of confusing. Well, you would think if A equals B and B equals C, then A must equal C, but it's not the case. We've had several studies so far with niacin, which is a B vitamin in high doses. It lowers triglycerides and raises HDL. That when added to a statin does not reduce the risk of heart attacks. We have several studies with fibrates. These are drugs like Tricor and Lopid that, especially the studies with Tricor, no benefit, no reduction in heart attacks, except in what's called a post hoc analysis, looking at a subset of people, not the entire population. The subset that had high triglycerides and low HDL to begin with seemed to benefit from these drugs, fibrates. But so far, and we have studies infusing HDL intravenously that don't reduce the risk of heart disease so far. So it's interesting. We have recently seen data from people who genetically have lower triglycerides, and they are protected from heart disease. And we know that high triglycerides are associated with low HDL. You lower the triglycerides, you raise the HDL. Usually. We've been so focused on HDL for the last few decades and have paid so little attention to triglycerides when it turns out maybe all the action is with the triglycerides, and what's happening with the HDL is not really causal. It's just sort of associated with where the action really is. Yes. The ratio. Yeah. You hear about the total cholesterol to HDL ratio. It's a very powerful predictor of events. What hasn't been shown is that raising HDL, which of course would lower the ratio, the lower the ratio, the better. Raising HDL has not been shown to reduce the risk of heart disease, but the ratio is a good predictor. In fact, HDL is a good predictor. If you have low HDL, you're at increased risk, but that doesn't mean that the low HDL is the cause. Yes? Is it possible to have high triglycerides and high HDL? Yes. And there are a couple of examples. Alcohol tends to raise triglycerides and HDL. Estrogen, same thing, will raise the triglyceride level, especially if you take the estrogen orally. By skin, not so much. So those are a couple of examples. Usually there's an inverse relationship. High triglycerides, low HDL. Stents are a good treatment for angina. True or false? Okay, so not so sure. Stents are definitely a good treatment for angina. I am being very diplomatic, though, by choosing this question. And the reason I say that is that this is what patients should be informed of before they have an elective angioplasty or stent procedure. What I mean is that, well, I'll show you. If you ask a bunch of people who have received informed consent to undergo a stent, these are stable patients. These are not people who are having a heart attack. A stable patient. They've signed. They understand. They're going to have the procedure. And you ask them, well, do you believe that this procedure will reduce your risk of a heart attack? 88% say yes. Do you believe it'll reduce your risk of a fatal heart attack? 82% say yes. Now, I participated in a notorious study. Notorious if you're one of my brethren in the interventional cardiology community. They hate this study. It's called the COURAGE trial. In the COURAGE trial, we took people who were stable. They were not in the middle of a heart attack, but most of them had angina. And we randomly assigned them to get a stent and good medical therapy versus no stent and good medical therapy. And we compared the two groups over 4.5 years to see what the heart attack and death rate were. And they were the same. As you can see, this is the medical therapy group in white and the stent group in green. There was just no difference. And so all these procedures are being done to put in stents when people believe that it's to prevent a heart attack. But so far, no proof. But if you have a lot of angina, getting a stent is a good treatment. it improves quality of life. Now, medical therapy also is a good treatment for angina, but it's not as good as a stent for a period of up to 3 years. After 3 years, there's no difference between medical therapy and a stent. How many patients know this before they sign on the line to undergo a procedure? Usually not very many. Statins prevent heart attacks. True and false? Yeah, the answer is absolutely true. Statins, it's weird. This drug class has been studied more than any other drug class, probably more than aspirin has been studied. And there's so much misunderstanding. I have so many patients, I had them in Nashville and I have them in California, that I see who are very apprehensive or absolutely have decided they do not want to be treated with a statin. They're worried about the effect on their memory. They're worried about the effect on their muscles. They're worried about liver damage. And there's no conclusive evidence that statins hurt cognitive function. There's virtually no evidence that statins will injure the liver. There are very rare cases. In fact, the FDA used to recommend monitoring of liver function tests on statins. They've removed that recommendation because it just never happens. And muscle side effects definitely occur. And they might occur in maybe 5% of people who take statins. And I hate it that somebody who should be on a statin is refusing when they might have a lot of potential benefit. Now, in terms of benefit, here's one of the types of slides that I was told not to show. On the x-axis is the LDL cholesterol level. And on the y-axis is the rate of heart disease. It says CHD, it's for coronary heart disease events, heart attacks and fatal and non-fatal heart attacks. And this is a line showing that the lower the cholesterol, these are a number of studies, the lower the cholesterol achieved, the lower the event rate. And some of these have like a P for the placebo group, and then here's for the simvastatin, or the active drug group. So there's very consistent evidence across many different studies that have been done. And here's another slide showing now on the x-axis, again, the LDL cholesterol. On the y-axis is the change in atheroma volume. That means with an intravascular ultrasound, a little wire that goes inside the coronary arteries, they're measuring the amount of plaque. And the plaque, this has to go back to progression and regression. The lower the cholesterol, you can actually, if you lower it, in this case it's below 70, you can achieve regression. This is doing an intravascular ultrasound at one point in time and then repeating it sometime later. After aggressive therapy, you can shrink the plaque with statins. So they prevent heart attack, they shrink plaque. They're really one of the best things that the pharmaceutical industry has developed. Should you take an aspirin every day? I know that we still have a few minutes. So this is beyond 10 questions. Yeah, so the answer is it depends. And it depends on your risk. Now, outside, there is somewhere, a place where you can get your risk. And what's the name of the station?
There's a biometric station.
There's a biometric station. And in that place, you can get your cholesterol tested, finger stick, your blood pressure. And then you'll know your age, sex, and whether or not you have diabetes or smoke. And you answer those questions. I'll go back to the other slides. You put in the data and you get a risk estimate of what is your risk of having a heart attack or a stroke over the next 10 years. And if you are at high risk, then it makes sense to be on aspirin. So if you've had a heart attack, if you've had a stroke, if your risk is at least 10% over the next 10 years, different people would draw the line at a different place, but if your risk is elevated, then low-dose aspirin makes sense. Defined in this country as 81 milligrams. It used to be called baby aspirin. I put in this bullet colon cancer because there appears to be a cancer prevention benefit from aspirin, specifically colon cancer. So, for example, if colon cancer runs in your family, that might be another reason to take aspirin. On the other hand, if you are at low risk, if you have an intolerance of aspirin or for some reason a high risk of bleeding, aspirin's not a good idea for you. In general, the risk of a serious bleed is 3 in 10,000 each year. Do anti-inflammatories work the way aspirin does? No. Aspirin, good for the heart. Non-steroidal, other non-steroidal anti-inflammatory drugs, bad, unfortunately. Even naproxen, Motrin. So I've got one more minute. Should you take a statin? I'm sort of yes or no, and again, it depends on your risk, but here are the guidelines. If you have coronary artery disease, yes. If you have really high LDL, yes. If you have diabetes, yes. If your risk with this at this biometric station is over 7.5% risk of stroke or heart attack in the next 10 years, yes. And if you say, I don't care what you say, statins are bad, and you're in my office, then I'm going to order a coronary calcium scan if I think you should be on a statin, and we're going to get a picture. And if you have calcium in your coronary arteries, you might change your mind, because that's a sign that you have atherosclerosis. I'm going to stop there, and let's see.
Just wanted to let you know the station is called Know Your Numbers. In the back of your program, you can record your results.
Okay, I'm going to stick around for questions. Thank you very much for your attention.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.